So this project basically, the background for this project was that I strongly felt that in our clinic system, when we get referral for early CKD or patients with hypertension who do not have controlled hypertension, that they were not on diuretics. And as you know, that salt retention or hypervolemia plays a huge role in the pathogenesis of hypertension in general population, as well as like definitely in CKD. So if volume retention is the main pathogenesis, then either low salt diet or diuretic will be the treatment. And you know how it is easy to achieve low salt diet when every single thing you buy from outside has salt already, whether it's cooked or uncooked. So that's not very, very practical if you do not cook from scratch every day, 3 times a day. So you end up having that high salt. So the role of diuretics becomes very important. So when we are seeing these patients in our clinic, many of those patients are not on diuretics. So I just wanted to see, like, what is the reason that these patients are not on diuretics? What is the percentage of them, and what are the reasons behind it? So that was the whole background. I started working on it. So first I had to look how many CKD patients out there with uncontrolled hypertension and how of them are on diuretics. So doing that project, I realized that many of these patients, they are not even getting screened for CKD. And then many of them, then if they were screened, they will not have the diagnosis of CKD in their chart. So it was, the question is like, they just had that GFR done for some other reason, or a primary care were looking for CKD screening. So that's how this whole thing started, because my main thing was like, how many patients with these uncontrolled hypertension with CKD are on diuretics? But then I realized many of these patients, uncontrolled hypertension, they are not even being looked for CKD, or if they were looked for, they were not even recognized for CKD. So that's how this whole project started. As I said, I was working at the VA mostly at that time. And then second thing, VA has this well-defined data warehouse. So I can easily access a big chunk of population. On the other hand, for other hospital care system or medical system, you may not have a well-defined cohort. So that's why I stayed, I chose to do VA. And the CKD screening has been recommended in patients who are at high risk of developing CKD. So that includes basically mostly the diabetes, hypertension with previous family history, or heart disease, and then ethnic minority races. So I kind of chose to stay just with diabetes and hypertension, because these are responsible for 80%, 90% of the CKDs. So I'm like, let me just focus on these two groups because they have well-defined ICD-9 and 10 criteria. So I can be that I can have a very clear, clean database. So I chose to have patients who have been seen in primary care clinic, and to ensure that these are continuity patients for their primary care clinic. They just did not come one time for some PRN issues. So we chose those patients who were seen in primary care clinic at least twice within 18 months. So those kind of define, these are the continuity primary care patients, then who have diabetes and hypertension. So and then our duration of cohort was basically September 2012 to October 2012 to September 2019. And once we had that cohort, so it was, I think, final cohort number was about 270,000 patients. And then we looked at chart for documentation of serum creatinine or eGFR, which kind of like tells you about the CKD, and presence of urine protein or albumin along with urine creatinine. So we looked those values in the chart, how many times patients had those documented. So out of those patients who have these documented, then we looked at how many had eGFR below 60 and how many had urine albumin creatinine ratio more than 30 milligram per gram, which these two criteria define CKD. And to call them CKD, you have to have these values at least twice 90 days apart. So that's how we kind of first identify our study cohort. Then we looked at the CKD screening, how many of these patients had the eGFR or urine albumin urea in the chart. And then we looked at how many were had defined CKD. And in those patients who had these defined CKD by those definitions, we looked at how many of them had the ICD-9 or 10 code for the CKD. And it could be generalized CKD or hypertensive CKD or diabetic CKD. They are like variety of codes. So we look for those, as well as if they had referral for nephrologists. So that kind of tells us that those primary care providers thought about, like they looked at those screening tests, they identified that patients have CKD. And so they know that these patients have CKD. And after that, once we find, have patients like these were screened versus not screened, these were recognized patients for CKD versus not recognized, then we looked at multitude of clinical variables, like their demographic, their smoking history, or their race, or the time of entry into the cohort, or their CKD staging, or comorbidities. And then we also looked at like how many times they were seen by the primary care or by specialty care, or they had the procedure done where they need contrast, because then you need like serum creatinine measured before contrast, or what medications they had. So all these things we kind of thought of all the possible factors which would be prompting some providers to order serum creatinine, eGFR, to look for those factors and take those out. So then you tell like, okay, this test was ordered for the screening purposes rather than just as a like bystander for something like that.